सभी को मेरा सादर प्रणाम. In this video, I shall be discussing about the diagnosis and management and the recent changes and the updates which have come up in the management of diabetic ketoacidosis in children, and the guidelines have been given by the Indian Society of Pediatrics and Adolescent Diabetes. It was given in the year 2022, but this is the latest which needs to be followed. So, as for any piece of evidence-based medicine, some children may require specific treatment that, in the judgment of the treating physician, may occasionally be outside the range of the options present in the guidelines. Hence, clinical judgment should be used to determine optimal treatment for the individual child, and timely adjustments to treatment should be based on ongoing clinical and biochemical monitoring of the response to treatment rather than following the guidelines verbatim, same to same. Biochemical criteria for diagnosis includes hyperglycemia, that is blood glucose more than 11 millimole per liter, more than 200 milligram per deciliter, venous pH less than 7.3 or serum bicarbonate less than 18 millimoles per liter, and ketonemia, that is blood beta hydroxybutyrate more than equal to 3 millimoles per liter, or moderate to large ketonuria, which is typically more than equal to 2 plus. Now, serum bicarbonate concentration alone can substitute for venous pH in case you don't have the facility to monitor venous pH. Although not universally available, blood beta hydroxybutyrate levels they should be measured, and wherever the level is more than equal to 3 millimoles per liter. So this will be a sensitive indicator for DKA, but the levels more than equal to 5.3 millimole per liter holds optimal accuracy for predicting the diagnosis of DKA in children. But there are certain caveats to the diagnosis of urinary ketones. First, that urinary ketones detect only acetoacetate and acetone, but not beta hydroxybutyrate, which is the main ketone in DKA. Therefore, it can underestimate the severity of ketonemia. The second thing is that several sulfhydryl containing drugs like captopril, N-acetylcysteine, mesna, penicillamine, and valproic acid, which are partly eliminated as ketone containing metabolite, give false positive ketone results in urine. And the third thing is that expired or improperly stored urine test strips can also give false negative results. So as a crux, ketonemia is to be believed and ketonuria is not to be considered for diagnosis of DKA. So one may ponder as to why has the severity been classified, even though the approach to treatment remains the same irrespective of the severity. Treatment strategies may vary. For example, mild DKA may require no insulin infusion at all. Classifying the severity also helps in prognostication, even though outcomes even in severe DKA are generally complete recovery. So mild DKA is venous pH less than 7.3, and in case it is not available, serum bicarbonate less than 18 millimole per liter is also mild. Moderate is pH less than 7.2 or serum bicarbonate less than 10 millimole per liter, and severe is pH less than 7.1 or serum bicarbonate less than 5 millimoles per liter. Clinical estimation of the degree of dehydration is imprecise in DKA and shows only fair to moderate agreement among the examiners. Therefore, it has been proposed to assume in mild DKA, that is conditions in which venous pH is less than 7.3 and bicarbonate less than 18 millimoles per liter, we must assume that the child has mild dehydration or 5% dehydration. Moderate DKA implies moderate dehydration as per these guidelines, that is 7% dehydration, and severe DKA as per these guidelines can be assumed to have severe dehydration, that is 10% dehydration. But as per me, the severity of DKA would suggest the fulminancy of the process and severity of the pancreatic insufficiency instead of the severity of dehydration. So personally, I think that we must calculate the fluids maybe with somewhere between 7 to 10%, that is between 8 to 8.5%, as given in the Milwaukee protocol of the Nielsen. Laboratory markers like increased serum urea nitrogen and anion gap at presentation, these rather more strongly correlate with volume deficit and the degree of dehydration. Pathophysiologically, we must know that hyperglycemia and hyperosmolarity, They are because of increased glucose production by the liver and the kidney via glycogenolysis and gluconeogenesis, and because of impaired peripheral glucose utilization. Ketonemia and metabolic acidosis are because of insulin deficiency, high counter-regulatory hormone concentrations which also increases lipolysis and ketogenesis. Osmotic diuresis, dehydration, and hyponatremia, hypokalemia, hypophosphatemia, and hypomagnesemia are because of hyperglycemia exceeding the usual renal threshold of approximately 10 millimoles per liter, that is 180 milligrams per deciliter. They are also because of hyperketonemia and vomiting associated with severe acidosis. And insulin resistance is because of hyperglycemia and stress hormone production. Clinical manifestations include dehydration, deep sighing respiration, as you will be listening in an audio just now. Nausea, vomiting, and abdominal pain that may mimic acute abdomen, and confusion and drowsiness. So this is the patient which we had recently managed, and the patient came with a pH of 6.8 and went off well. Euglycemic ketoacidosis is another terminology which has come up in these guidelines, and it is seen in partially treated children and those who have consumed little or no carbohydrate and hence have manifestations of modestly elevated blood glucose concentrations only. This is typically found in conditions like starvation or fasting, low carbohydrate, high fat diet, or off-label use of SGLT2 inhibitors. Management of euglycemic ketoacidosis should follow standard DKA protocol itself, except that the dextrose containing fluid should be started earlier because the blood glucose concentration is obviously not very high. So it should be started immediately after initial volume expansion. So in a way, an example of the same is starvation ketoacidosis. Hemoglobin A1C is done to confirm the diagnosis of diabetes or as an indicator for duration of hyperglycemia, because typically it is this hemoglobin gets replaced every 3 months. So if hemoglobin A1C is elevated, then it implies that the blood glucose has been elevated for a minimum duration of 3 months prior to the current scene. Complete blood count frequently shows leukocytosis with shift to left even without infection, and this is very important that even without infection you will get polymorphonuclear leukocytosis, and it is mainly because of stress. Infection evaluation should hence be based on the clinical scenario and not on the value of the WBC count. If laboratory measurement of serum potassium is delayed, you must perform an ECG for baseline evaluation of potassium status. In this ECG, you can see tall tinting T waves, which is manifestation of life-threatening hyperkalemia. Now, a simple mnemonic to keep in mind the salient points you have to manage is FLIP, where FL stands for fluids, I stands for insulin, P stands for potassium, and P stands for phosphate. So these are the 4 important parameters which you have to take care of while managing a patient of DKA, and of course you have to take care to prevent cerebral injury. Earlier cerebral edema is what we knew, but now the term used is cerebral injury. In any condition, the fluid which needs to be given is calculated by the formula. It is actually the fluid which is to be given includes maintenance fluid, the deficit correction, and replacement of the ongoing losses. So a simple mnemonic to remember is the fluid which needs to be given in any condition, be it diarrheal dehydration, be it AKI, be it anything, you have to manage MDR, that is maintenance, deficit, and replacement of ongoing losses. Now we give 10 ml per kg of IV fluid per percent dehydration. So 1% deficit implies that 1 into 10, that is 10 ml per kg of IV fluid needs to be given for replacement of deficit. Suppose there is moderate dehydration, that is 7.5%, and the weight of the child is 10 kg, then 7.5% is equal to 75 ml per kg. and into weight it will be 750 ml, which needs to be replaced in this child. So accordingly, the fluid, if suppose if the child is presented in DKA, the fluid needed to be given to this child is 1000 ml of maintenance fluid calculated as per the holiday cigar formula, 750 ml of replacement fluid or the deficit, 750 ml of the deficit correction, which we have calculated over here, and the ongoing losses need to be replaced. Of course, urinary losses don't need to be replaced, which I shall be discussing later. The type of fluid which needs to be given is 0.45 to 0.9% saline, aiming to replace the estimated fluid deficit over 24 to 48 hours. Decisions regarding the use of isotonic versus hypotonic solution for deficit replacement should depend on the clinician judgment based on the child's hydration status, serum sodium concentration, and osmolality. And although rehydration generally is planned to occur over 24 hours or longer, DKA typically resolves before 24 hours. And so the remaining fluid deficits need to be replaced by oral intake after transition to subcutaneous insulin. What changes there in these guidelines is that earlier the deficit replacement was to be done over 1 hour, but now this time has been reduced to 20 to 30 minutes. This is very important change. Earlier there was a risk, earlier people believed that there would be a risk of cerebral edema if we hydrate very fast, but now it has been seen that there is not much of difference. Recent evidence suggests that abnormalities in cerebral perfusion and the hyperinflammatory state caused by DKA play important roles, and that variations in fluid treatments are likely to have minimal effects, and therefore you can give fluid over 1 hour or 20 to 30 minutes, but can give over 20 to 30 minutes. This is the important change. There are some important practice points which we must remember while giving resuscitation fluids, which I wanted to highlight over here because every one of us are managing these cases. Volume depletion but not in shock. Give 0.9% saline 10 to 20 ml per kg infused over 20 to 30 minutes. If tissue perfusion is poor, initial fluid bolus volume should be 20 ml per kg. In the rare child with DKA in shock, more than one bolus of 0.9% saline may also need to be given at the rate 20 ml per kg as quickly as possible through a large bore cannula with reassessment of circulatory status after each bolus. The fluid should be used as the fluid used should be crystalloid and not colloid, and the osmolality we have already discussed, 0.45 to 0.9. Urinary losses should not be replaced because polyuria is, as it is seen in patients with diabetes secondary to glucosuria, and this will improve with treatment. But urinary losses replacement may be required in patients with a mixed presentation of DKA and HHS. Ensure positive fluid balance for HHS, that is hyperglycemic hyperosmolar state. In obese children, this is important. Use the ideal body weight for fluid calculations. But using this is not very essential if the fluid calculations as per their current weight, that is as per the obesity weight, exceed those typically used in adult protocols, then in that case only adult DK fluid protocol should be used, and the adult DK fluid protocol is 1 liter maximum per bolus and 500 ml per hour of fluid infusion. So this is another very important parameter, that ideal body weight does not need to be used even in obese children. But yes, the maximum dose should not exceed the adult dosage. The use of large amounts of chloride-rich fluids combined with preferential renal excretion of ketones over fluoride is often associated with development of hyperchloremic metabolic acidosis, and when hyperchloremia develops, a persisting base deficit or low bicarbonate concentration can be erroneously interpreted as being due to ongoing losses. To avoid this misinterpretation, measurement of bedside beta-hydroxybutyrate levels or calculation of anion gap if beta-hydroxybutyrate levels is not available should be used to determine resolution of ketoacidosis. Hyperchloremic acidosis is generally asymptomatic and resolves spontaneously, and chloride load can be reduced by using potassium salts other than potassium chloride or by using fluids such as ringer lactate or plasma lite, in which a portion of the chloride is replaced by lactate or acetate respectively. Dose of insulin used is 0.05 to zero point 0.1 unit per kg per hour of regular soluble insulin. Lower dosage can be considered for children with pH more than 7.15, that is with moderate to mild DKA. An IV insulin bolus given at the start of therapy can precipitate shock by rapidly decreasing osmotic pressure consequent to decreasing blood glucose, and it can even exacerbate hypokalemia, so it should be avoided. If IV cannulation is not possible due to severe dehydration, insulin can be administered intramuscularly. See, these are very important practice points which rather I also did not know. So this is, I think everyone should know this. Central venous catheters should not be used for insulin administration because large dead space may cause erratic insulin delivery. Dose of insulin should usually remain at 0.05 to zero point 0.1 units per kg per hour until resolution of DKA, which is defined as pH more than 7.3, bicarb more than 18 millimole per liter, and beta hydroxybutyrate levels low. Dose of 0.05 units per kg per hour, that is 0.03 units per kg per hour for less than 5 years of age with mild DKA, is usually sufficient to resolve the acidosis. Subcutaneous administration of short-acting regular insulin every 4 hours is another alternative in mild DKA when IV infusion or rapid-acting insulin analogs are not available. A suggested starting dose will be 0.13 to 0.17 units per kg per dose of regular insulin given every 4 hours. Doses are increased or decreased by 10 to 20% based on the blood glucose level before the next insulin injection after 4 hours, and dosing frequency can be increased to every 2 to 3 hours if acidosis is not improving properly. To prevent rebound hyperglycemia, the first subcutaneous injection should be given 15 to 30 minutes with the rapid acting insulin before stopping the insulin infusion to allow sufficient time for the insulin to be absorbed. With long-acting insulin, overlap should be longer and rate of insulin administration should be gradually decreased. For example, for children on a basal bolus insulin regimen, first dose of basal insulin may be administered in the evening and the IV insulin infusion is stopped the next morning. The regimen, dose and type of subcutaneous insulin should be decided as per the local preferences and circumstances. And after transitioning to subcutaneous insulin, frequent blood glucose monitoring is required to avoid marked hyperglycemia and hypoglycemia in the immediate period. One needs to monitor capillary blood glucose concentrations at least hourly, but this must be cross-checked with lab venous glucose values because it might be inaccurate, especially if there is poor peripheral circulation and when plasma glucose levels are extremely high. Continuous monitoring of interstitial glucose during DKA is being evaluated. Serum electrolytes, blood urea nitrogen, calcium, magnesium, phosphate, and blood gases should be checked at admission and every 2 to 4 hours or more frequently as clinically indicated. Blood beta hydroxybutyrate concentrations if available are useful for tracking DKA resolution, and point of care beta hydroxybutyrate measurements correlate well with the reference method up to 3 millimoles per liter but are not accurate above 5 millimoles per liter. A word about potassium, which is a very important and dangerous cation during the management of DKA. Potassium replacement is required regardless of the serum potassium concentration only except if renal failure is present, and if potassium is more than 5.5 millimoles per liter, you must defer the potassium replacement until urine output is documented. Begin IV fluid replacement with non-potassium containing fluids and measure potassium hourly. If potassium, however, is less than 3.5 millimoles per liter, then in rare case, one may start potassium replacement at the time of initial volume expansion itself before starting insulin therapy. So these are some very important practice parameters. I repeatedly stress here again. Rarely one may even need to defer insulin treatment and give a bolus of potassium not to exceed 0.5 millimoles per kg per hour along with cardiac monitoring. So every decision is clinician's own discretion, and this is what the beauty of medicine is. The starting potassium concentration should be 40 millimoles per liter in the infusate and subsequent management depending on the serum potassium levels. Potassium phosphate may be used together with potassium chloride or acetate. For example, 20 millimole per liter potassium chloride and 20 millimole per liter potassium phosphate, or 20 mm millimole per liter of potassium phosphate and 20 millimole per liter of potassium acetate. Administration of potassium entirely as potassium chloride contributes to the risk of hyperchloremic metabolic acidosis, and potassium replacement should continue throughout the IV fluid therapy. The maximum recommended rate of IV potassium replacement is usually 0.5 millimoles per kg per hour. And if hypokalemia persists despite a maximum rate of potassium replacement, then the rate of insulin infusion can be reduced. Bicarbonate therapy is not recommended except for treatment of life-threatening hyperkalemia or severe acidosis, that is venous pH less than 6.9 with hemodynamic instability. Bicarbonate therapy is implicated in causing paradoxical CNS acidosis, and rapid correction of acidosis further aggravates hypokalemia. So how does this bicarbonate level improve? Actually, insulin stops further keto acid production and allows the keto acids to be metabolized, and this generates bicarbonate, which leads to spontaneous correction of acidosis with insulin therapy. So this is a word about the phosphate therapy. I don't think many people are interested in knowing the same. A word about cerebral injury. Earlier, the term cerebral edema was used, but now, because actually the cerebral edema is non-cytotoxic, so it has been changed to the term cerebral injury. So, warning signs and symptoms of cerebral injury in a patient of DK include onset of headache or vomiting after beginning treatment or progressively worsening headache, slowing of heart rate not related to sleep or improved intravascular volume, change in neurological status which includes irritability, lethargy, confusion, incontinence, and specific neurological signs like cranial nerve palsies and decreased oxygen saturation. What is important to note is that hypertension occurs commonly in children with DK and should not be considered as a warning sign for cerebral injury per se in the absence of other findings, because we already know that there is a catecholamine surge in patients with DKA and this can lead to hypertension. The risk factors for cerebral injury include elevated serum urea nitrogen more than 20 milligrams per deciliter, severe acidosis pH less than 7.1, severe hypocapnia PCO2 less than 21 millimeters mercury, age of the child being less than 5 years, and bicarbonate treatment in severe acidosis. So, in case the patient has any or all of these risk factors, one must be prepared with mannitol or hypertonic saline at the bedside with the dose already calculated because it is life-threatening or fatal. One must initiate the treatment as soon as the condition of cerebral injury is suspected and adjust fluid administration rate as needed to maintain normal blood pressure. Hypotension that may compromise cerebral perfusion pressure should be avoided. Give mannitol 0.5 to 1 gram per kg IV over 10 to 15 minutes. The effect of mannitol is apparent after 15 minutes and is expected to last for around 2 hours. If necessary, the dose can be repeated after 30 minutes. Hypertonic saline, that is 3% saline, the dose is 2.5 to 5 ml per kg per 5 ml per kg given over 10 to 15 minutes. 2.5 ml per kg of 3% saline is equimolar to 0.5 gram per kg of mannitol, and it may be used as an alternative to mannitol or in addition to mannitol if there has been no response to mannitol within 15 to 30 minutes. For further management, one must remember that unless absolute necessary, one must avoid placing a central venous catheter because of the high risk of thrombosis, and in case it has been inserted, the catheter should be removed as early as possible. Mechanical and pharmacological prophylaxis with low molecular weight heparin should be considered for those people with central venous catheters, especially children more than 12 years, that is adolescents and adults. Insulin should not be given through a central line unless it is only available option because its infusion may be interrupted when other fluids are being given through the same line depending on the blood glucose values. And bladder catheterization usually is not necessary but should be considered if the child is unconscious or is severely ill. There are some pertinent calculations in the management of DKA. First is anion gap, which is sodium minus chloride plus bicarbonate. Normal value is 12 plus minus 2 millimole per liter. In DKA, the anion gap is typically between 20 to 30, and in case the anion gap is more than 35 millimoles per liter, it suggests concomitant lactic acidosis and one must manage the same as well. Effective osmolality in milliosmol per kg is twice sodium ion plus plasma glucose value in millimoles per liter. The normal value is 275 to 295 milliosmoles per kg. And corrected sodium is measured sodium plus 1.6 into plasma glucose minus 5.6 upon 5.6 millimole per liter, or measured sodium plus 1.6 into plasma glucose minus 100 by 100 milligrams per deciliter. Now coming on to a closely related subject, just one seen on the same, hyperglycemic hyperosmolar state. The criteria includes all of the following, that is plasma glucose more than 33.3, that is 600 milligrams per deciliter, indicate is just 11 and 200 respectively. Venous pH more than 7.25 and arterial pH more than 7.3. In DKA, venous pH is less than 7.3. Serum bicarbonate more than 15 millimole per liter. In DKA, it is less than 18 millimole per liter. Small ketonuria absent or mild ketonemia, where it is moderate to large ketonemia. Effective serum osmolality being more than 320 milliosmol per kg, which is the principal differentiating feature between HHS and DKA. In HHS, the goals of initial fluid therapy are to expand the intra and extravascular volume and restore the normal renal perfusion and promote a gradual decline in corrected serum sodium concentration and serum osmolality, which is not of concern nowadays in DKA. In HHS, begin insulin administration at still a lower dose, that is 0.025 to 0.05 units per kg per hour, once plasma glucose is decreasing less than 3 millimoles per liter per hour with fluid alone. Now revising, the rates of fluid administration both as initial fluid boluses to restore circulation and as ongoing deficit replacement are substantially higher than for DK. So summarizing the salient points in these guidelines, biochemical criteria to diagnose DKA include serum bicarbonate less than 18 millimoles per liter, and it can be used standalone irrespective of the pH availability. A rough estimate of the degree of dehydration can be made from the severity of DKA, in that mild DKA is around 5% dehydration, moderate is 7%, and severe is 10% dehydration. Initial fluid bolus can be given rapidly over 20 to 30 minutes. It can be of 10 to 20 ml per kg, and even more than one bolus may be given if the patient is in shock. Subcutaneous administration of short-acting or regular insulin every 4 hours is another alternative in mild DKA when IV infusion or rapid-acting insulin analogs are not available. If the child is hypokalemic, one may start potassium replacement at the start itself, that is at the time of initial volume expansion, before starting the insulin therapy. The risk factors for cerebral injury include elevated serum urea nitrogen, severe acidosis, severe hypocapnia, age less than 5 years, and bicarbonate treatment in severe acidosis. Increased emphasis on differences in treatment recommendations for double HS and mixed presentation of ketoacidosis and double HS compared to standard treatment of DKA alone. Thank you so very much for a very patient listening and watching. In case you like the video, I request you to give a thumbs up and press the notifications icon, and do share your experience of managing patients with DKA, because recently we managed quite a number of them. And thank you once again, and please do share the knowledge with everyone so that we can improve the overall health of the children. Thank you.